My name is Onika Dainty. I'm 43 years old. Well, 42. I'm aging myself. I turned 43 in December. My first experience with psychosis was at the age of 24 years old. I've been hospitalized about 13 times. And outside of that window, that hospitalization window, I do live a full and robust life as a writer, a blogger, and a public speaker. And I enjoy things like hiking, gardening, thrift shopping with my grandma, reading, of course, writing, and just hanging out with my very large family.
My name is Caroline Walker. I work at CAMH, and what I do is I support the operation of a recovery college called the Collaborative Learning College. My position is predicated on having lived experience of mental illness. I also advise on studies about schizophrenia spectrum disorders as a lived experience advisor. My diagnoses are schizoaffective disorder, bipolar type, autism spectrum disorder, and obsessive compulsive disorder. I had my first psychotic episode the summer that I was 23 years old. I was hospitalized for 3 months in the general psychiatry unit at CAMH.
My name is Katie, Katie Stadelman. I have my master's in social work, and for the last 14 years I've been working in a pediatric hospital in the psychiatry department. And so what that means is I've been working in inpatient and outpatient settings with young people and their families.
Hello, my name is Narot Kabasakal, and I'm a registered social worker with 16 years of experience in mental health, crisis, and forensic settings.
Could you tell us a little bit about the most serious signs and symptoms that of psychosis that you've experienced?
I would have to say any auditory hallucinations, delusions. At one point, I thought I was the second coming of Christ and I could talk to God and the devil. I've experienced delusions of grandeur, so I thought that I was Mother Earth coming to stop the diaspora. I also think that I could start empires and businesses without much resources. I've experienced paranoia, thinking someone is out to get me, and I've experienced obsession for the real and for the imagined. So it could be a hypersexuality and hyper obsession. I call it manic love for, again, people that are sometimes there and sometimes not.
My psychosis at first was tied to my hypomania, so my delusions followed my elated mood. I thought that I would be deeply connected to everyone that I wished, some celebrities and some people known to me, and that they would recognize and love me in return. I was thinking about all the papers I was going to write for my senior courses and how brilliant they would be. My thoughts spun out from there, becoming less and less tethered to reality. For example, I thought that Oprah was my real mother and that the rapper Jay-Z was looking for me. During my first hospitalization, I frequently dissociated. My psychiatrist at the time said that I might have dissociative identity disorder. I did things that were totally out of character, such as loudly telling off one of the other patients for being a pimp. In one state of mind, I would be talking to my nurse Lloyd, and in another state of mind, I wouldn't know who he was.
Psychosis, I think it's important firstly to understand that it's a symptom. So when we talk about psychosis, it could be related to a primary psychotic condition, it could be a mood disorder, and sometimes there's actually medical causes to psychosis. So it's actually a symptom. It's not a diagnosis in itself. And that being said, there are common symptoms that can occur, and they usually fall into these two main areas, and they're called positive and negative symptoms. And I'll go through those a little bit. So they're called positive not because it's a good experience, but because it's adding on to the young person's experience or the individual's experience. So it's causing a symptom that was there, that wasn't there, to suddenly appear. So what that could look like is some common things, maybe a paranoid delusion. So a young person might feel like somebody is going to hurt them, or somebody might be following them. It might be, another positive symptom is an auditory hallucination. Some examples I've seen is where young people might start to hear religious references, or they might hear voices of people telling them to do certain things or telling them negative things about themselves. Another type of positive symptom could be like a visual hallucination where people see things in the room that are not there, that were not necessarily there. So that would be the positive symptoms. And the other types of symptoms are called negative symptoms. And this is because they're taking away from the experience of the individual. So things that typically present as negative symptoms might be difficult with cognition. So difficulty with memory. It may be that it's difficult to express thoughts. It might be a flat affect, difficulties with motivation, and kind of loss of interest in things that they might have been interested in before.
I would say the biggest challenge or difficulty I have faced when dealing with psychosis is the fear of death. Also the fear of confinement. More often than not, I have police that get involved in my wellness checks. Either I've called them or someone in the community has called them and told them I'm acting strangely. And they basically criminalize you. They treat you as if you're not someone who's unwell. They treat you as if you're a danger. And I've had instances where I've been thrown down to the ground, kneed in the back, and apprehended, they call it, not arrested. And it's been challenging. It's a challenging experience because you do feel like a criminal. And some of the things I've done to like mitigate things like that happening is I often will call fire and ambulance so they can witness what the police interaction is going to look like and feel like. I'll sing loudly. I will sexualize myself in some way because I find it disarms the police officers. And then the other aspect of that is once I'm sent to the hospital or taken to the hospital, I'm usually put on a Form 1. And a Form 1 is an involuntary hold. I'm usually in a psychiatric intensive care unit. And I'm more often than not, restrained. It's very barbaric. It's very hard to deal with. I know that I can be not necessarily physically violent, but I could be verbally abusive to staff. So they justify sometimes that with having 8 or 9 security guards try to strap me to a bed, and that in itself has its own set of challenges. And the way I kind of mitigate that, not necessarily stopping the restraint, but slowing it down a bit, is I take off all my clothes because they can't touch a naked woman.
Yeah, so when I was an inpatient at the acute care unit, I was brought into a form hearing. At the time, I was extremely afraid. I thought that the panel of people judging my fitness to decide to stay in hospital were actually judging whether I should live or die, and that they were going to murder me. Afterwards, my doctor told me that I did great. But if I had had a social worker with me in that room, it would have been so helpful to just orient me to reality, like, this is a form hearing. They're deciding how sick you are and whether you can make a good decision about staying in hospital. We want you to stay in hospital so we can help you get better. After this, we'll go back to the unit and we can talk about what happened and what that means.
Oh my God, so no one explained any of that to you, eh?
No.
They just kind of brought you into a room and started talking about you.
Supporting people with active psychotic symptoms can be challenging because it's difficult to engage someone in care when they don't believe they're unwell. Sustaining motivation, especially when insight is limited, can also be a hurdle in maintaining recovery. In such cases, we social workers must be creative and think beyond what we've been taught.
Often the young person doesn't have the insight themselves to understand that something is wrong. Everything feels very, very real for them, the experiences they're having. So a lot of the times they're not necessarily help seeking themselves. So the first people that might notice the symptoms are actually people that are within their lives. It could be family members, it could be staff at school or staff at the workplace that notice a change in behavior. And it's usually quite a marked change in behavior where it's different from their baseline. So they may start expressing things to loved ones or co-workers, or school staff around fears and anxieties that really don't seem to be in touch with reality. And I think it's important to recognize that this is from what their baseline is. So if somebody's been anxious before and they share anxieties and it's not a real change, less concerning. But if this is a marked change from what their baseline behavior is, people start to notice, and then they usually help connect them with services.
I think the biggest challenge is my verbal aggression. So, as I said to you before, my baseline can come and go rather quickly, and it does come and go in the hospital setting. So you never know which Onika you're going to get on which day. So I could be very help-seeking one day and very aggressive and non-compliant the next day, which makes it challenging. It's a challenging situation for the social workers as well as the healthcare professionals that are trying to assist me.
It can be really hard to watch the distress. And as a social worker, you usually are like, okay, I can help with some coping skills, or I can help challenge this negative thought. And with psychosis, sometimes you just can't, especially in the acute phases. So you have to kind of patiently wait for stabilization with medications. You're seeing families who have just so worried about their child and what is going on for them, and so it's really sitting with that. Remaining hopeful is very, very important. Yeah. So first, I'm going to explain what an inpatient psychiatry unit is like in the context of my work.
Please.
So within a hospital setting, there's usually a designated ward or unit that is for psychiatry. And so in order to be admitted into an inpatient psychiatry unit, there is usually quite acute symptoms. So there's things that are going on that need immediate attention, and that may be because of distress or fear for the young person's safety or well-being, and it can't be treated in an outpatient setting. So in our inpatient unit, there's a whole big team of people. So there's psychiatrists, social workers, occupational therapists, nursing staff, and as a social worker, you're part of an interdisciplinary team. So you're working with all of these professionals to help provide support and stabilization to the young person. So I was a part of a big team on that unit.
My second psychotic episode happened the next fall when I was 24 and lasted until the following spring after I turned 25. I was hospitalized for a month in the acute care unit in one of only 6 beds, which were for the most acutely ill patients in the hospital. A typical stay in the ACU was for a few days, but I stayed there for a month because of the severity of my psychosis. Because I also was suffering from a severe mood disorder, after the ACU, I was moved to the mood and anxiety inpatient unit where I stayed for 5 months. During this stay, I had 8 rounds of ECT and was trialed on several drugs before settling on clozapine, which has eliminated my psychosis for the last 15 years.
From a recovery perspective, the most effective treatments for psychosis combine medication, psychotherapy, and strong social supports. Antipsychotic medication can help reduce symptoms, but recovery goes beyond symptom control. It's about helping people rebuild meaningful lives.
as the psychosis starts to decrease, and as you start to kind of come out of the psychosis, what kind of challenges have you faced as you started getting better?
I think the biggest challenge is it's what the medical world calls baseline. When I'm in hospital and I reach my baseline, which is like night and day, it just seems to come overnight. When I get back to baseline, a lot of the staff don't realize I'm there. So they still feel a little threatened by me. They still feel fear. And there's a lack of understanding there as well. And it happens again when I'm released with my family and my friends. They're kind of just lying in wait to see when psychosis is going to rear its ugly head again. But it does take time. It takes time to help them understand I'm back. And it's fair that they feel that way because who knows how long I'm back for. Psychosis is a thing that it's not necessarily, you don't get better from it. It's always kind of lurking around the corner. And you never know when it's going to appear or how it's going to affect the people that you're around, your loved ones, et cetera, et cetera.
So when young people have are being discharged from the inpatient unit, it's generally not recommended that they just go back to life full on, sports, school, work. That can be really overwhelming. So there are specific types of programs in outpatient settings that support transition back into the community. At the hospital I worked at, it was what was called a day treatment program. So young people would come to the program during the daytime hours, usually around 9 to 3, and then they would go home and be with their families in the evening. This provided great opportunity to work on goals for the young people. It would be an amazing opportunity for families to get used to the transition, just really helping build a supportive transition to make sure that the young person could be as successful as possible. They might work on school. We would do really fun community outings.
Oh, nice.
So we could go to the Y. We went to Canada's Wonderland a few times, which not my thing, but yeah, it was.
Every time I think about social workers and the career that I've had with social workers, I think about one specific social worker. We'll call him T. He was with me from my 6th episode, and he allowed me to berate him for probably about an hour on the follies of men and how I couldn't stand men because he knew my trauma, he knew my file, he knew my case, and he just calmly as ever said to me, I understand where you're coming from. If you give me a month to work with you and you're not happy with my work, I will step down, I will back off and I'll get you a new female social worker. And T and I worked together for 6 years.
Wow.
We worked together for 6 years and he was like my big brother. And he's just like, he was a huge part of my remission, going into remission recovery. I know people say one thing or the other, but I say remission. So he was a huge part of that remission period of my life at the time.
So I had a really phenomenal social worker named Lysana Bertoli, who was my case manager during my 2nd psychotic episode when I was in the mood and anxiety inpatient unit at Center for Addiction Mental Health. I have schizoaffective disorder, which is a combination of psychosis. So it's one of the schizophrenia spectrum disorders and a mood disorder, in my case, bipolar disorder. When I was discharged, I wasn't allowed to go back to my studio apartment where I lived alone. They wanted me to live in a group home. So Lysana found me a non-depressing group home called George Herman House, which was in a lovely home in the annex. She also got me on ODSP so that I could pay the rent at the expensive group home. And getting on ODSP was hard for me because I thought that it meant that I would be disabled forever and never recover. When I was ready to leave the group home because I didn't like living communally, she found me a 1-bedroom apartment with regeneration community services. And then when I didn't feel safe there because of the lack of security, people, for example, were using drugs right outside my door. She got me on the list for the YWCA. She got me enrolled in one of their support groups so that I would get to the top of the list much faster. And then I moved into permanent housing 12 years ago, and I live there still. And securing safe housing was important for my recovery and also for accommodating my autism, because living by myself is crucial because I need a lot of alone time.
At times, we go beyond treatment recommendations found in diagnostic manuals and beyond the therapy modalities we learn in school. We must think on our feet, be creative, and simultaneously uphold the ethical responsibilities set out by our professional college.
If you were to talk to social work students, what do you think they need to know about helping people with psychosis?
For me, the biggest thing, as I said earlier, it's you're never going to know what psychosis is like. You're never going to understand what that looks like, feels like, sounds like. Like, you'll know what it sounds like a little, but you won't understand what it's like to go through and have that experience unless you've had that experience yourself. You can read the books. You could talk to people who have been in psychosis. You could study your butt off, but it's about trying. Mm-hmm. It's about empathizing. It's about trying to find the connection between you and that individual who is terrified. And it's about being fearless. And it's about, and that's the thing, you don't think in social work you have to necessarily be fearless, but people who struggle and deal with psychosis are some of the most challenging people you will ever meet in your entire life. And they don't always look a certain way or act a certain way or say a certain thing. They're very unexpected. They're very surprising. And I think it's just important to continue to try and to continue to try to find the connection between yourself and your clients, because there is something there. There is something to connect you to. There's a reason that you've been put together by the universe or whoever, and there's something you can do to help them. You just have to have the patience. You have to have the psychoeducation, the understanding, and you have to have the passion for the job, because if you don't, you'll burn out. So yeah, like, it's just find the gem, find the hidden gem, find the connection, because there is connection in chaos.
So I am autistic. I was only identified last year when I was 39 years old. I've been seeing psychiatrists since I was 16. Probably I've saw about 20 psychiatrists in my life, and none of them mentioned autism, including there was a cognitive assessment that I did that described my autism without identifying it. Mm-hmm. So also, gender bias means that many autistic women are diagnosed with borderline personality disorder. And myself, I was in a BPD clinic prior to my second psychotic episode. And I think that all social workers should have knowledge about neurodivergence, because I could have been identified much earlier. I could have had the insights that I've gained about myself so much sooner. I could have been accommodated better at school and at work. And so many things would have made more sense in the light of this diagnosis, including many parts of my mental illness. And I had all the typical symptoms in people assigned female at birth. I had a bit of delay in learning speech. I relied on others to speak for and guide me. I had intense special interests. I struggled with making and keeping friends. I masked my repetitive behaviors so that I wouldn't be bullied for being, quote, retarded. Also, I wanted to bring up the point that repetitive movements that are characteristic of autism are often stereotyped as crazy. So, for example, rocking back and forth or fidgeting, it's not crazy. It's called self-stimulating behavior, or stimming. And stimming helps an autistic person self-regulate. And it's a sign of being unmasked, whether it's on purpose or because we're too tired to mask. So an autistic person who is unmasked is actually healthier than a normal-looking autistic person because they're certainly masking in order to look normal. And I'm only now reevaluating my experiences throughout life, including my psychotic episodes, in the light of finally knowing this about myself.
I think it's important, like in psychosis, it is quite medicalized initially because medications are really important often for getting symptoms under control. But that being said, as social workers, we also have a really important role to kind of demedicalize stuff, like find out what's your favorite TV show, what's, like tell me some funny stories about yourself, like getting to know the person as a whole. It's not all about like symptoms and management. This is a really amazing person, and getting to learn all those things, and they can be really important in the recovery and helping the person feel comfortable.
I'm not my illness. I am not psychosis. I am someone who manages and deals with and lives with psychosis. I'm a woman who has different facets to her personality, whether it be a daughter or an aunt or a granddaughter or a cousin or a niece. I'm not psychosis. And that's one important thing that people need to realize about people who deal with psychosis. And another big thing for me is I now have, because I've had so many incidences, I now have what I call the roadmap for myself to get back to baseline, to get into remission, and I know what I need to do to stay in remission. No guarantee psychosis is not around the corner. No guarantee something isn't going to happen to spark it off, but I have that roadmap and I'm confident, and I'm okay with the fact that I deal with psychosis. I try to live a very full, as I said, and robust life in the interim. And one of the things I try to do is a lot of advocacy work, and I studied to be a peer support specialist, which is something I'm really passionate about. And to future social workers out there, if you get a chance to work with peer support specialists, they're kind of like the gatekeepers. They've experienced things and they've lived through things that you can only imagine, and that would really be helpful in connecting you with your potential clients. And it also bridges the gap between the mental health field and the professionals there and peer supporters, because they give hope and a level of understanding for mental illness that you just can't get, like I said, in books or watching videos. So my work as a peer supporter just has taught me so much about myself, and it's also taught me that there's just light at the end of the tunnel, and there's sunshine after the rain, and that's what I want to make sure people who are struggling and dealing with psychosis know too.
Watching someone move from crisis towards stability or redefine what recovery means to them is incredibly moving. It reminds me that hope is not abstract. It's practical and alive in small daily victories.
This work is extremely meaningful. You're on this journey with these families from admission to discharge to maybe readmission to hospital. You become so part of that journey with them, and it is difficult, but it's such a privilege, and it's just such rewarding work to be able to do that. I have a young person who's not young at all anymore, but their family sends me email updates and photo updates. We celebrated birthdays together, graduations while they were in hospital. Got to meet the Toronto Maple Leafs and the Raptors, and it was just such important work. And I think my advice for social workers kind of in any area is really that it's not always just the clinical skills where the work is happening. It's sometimes just the small moments of seeing a family in the hallway, or sharing a inside joke, or in a difficult situation trying to find kind of something to giggle about. Those are the things that build these like really strong relationships with the families, and the things that I know that the families appreciate, because it just really humanizes the experience. So yes, very rewarding work.
But over the years, I've learned that I can't fix everything. Supporting someone with psychosis means accepting uncertainty and resisting the urge to control outcomes. Advocating for people's rights, autonomy, and personhood, especially within systems that often overlook or pathologize them, has been some of the most meaningful work I've ever done.
Is there anything else that you'd like to share?
Not really. I would say, again, to the future social workers in the audience out there watching the video, it's a complex illness. It's got a lot of intricacies and complexities, but we are diamonds in the rough. We are definitely diamonds in the rough, and just be patient and be kind and be good humans, and just buff out that diamond and watch it shine.